Yes.
Dr. McClelland, going to ask you next about the relationships between SEBTS and other bodies and organisations during the time that you were director. So can I start by reference to your witness statement, WITN 6666001, and if we can go to page 64, please. So the bottom of the page, you were asked about the regular meetings between regional directors of the SNBTS. You say you believe the meetings were instituted by Dr. Cash when he was appointed as National Medical Director. We go to the top of the next page. You say the purpose in general terms was to ensure effective communication among the directors and to agree matters of policy and in some cases of practice. And then in the next paragraph you say, and this is in response to a question about the decision-making remit of the directors group, you say this: the authority or lack of it of these meetings was never totally transparent. The history of the SNBTS was one of independent evolution of each of its centres. By the time the directors' meetings started, each centre had a doctor in charge. If one refers to the job descriptions, it's difficult to define clear lines of responsibility and accountability. It was never clear to me that the directors had, as a group, had the authority to make collective decisions that affected the policies and procedures of all RTCs. So just pausing there, is it right then to understand that, to some extent in a similar way to England and Wales, the regional transfusion services within Scotland were largely autonomous?
Yes, I think it was a very similar situation.
And so the meetings that were had on a regular basis, as you described, they're instituted by Dr. Cash, would presumably be a means of exchanging information and debating questions, but not, as I understand your evidence, meetings that had a decision-making role.
I think the meetings did make decisions on quite a lot of matters, but I think they had to be consensus decisions. I think if there was serious disagreement among the directors, it was quite common for decisions to be kind of put on the back burner.
Outside of the regular meetings of the directors, were there other frequent or regular interactions that you had with colleagues in the other regional services in Scotland?
Well, there was a second series of meetings, which I think when I started was called the Coordinating Group. And I would say that it was quite similar in its meetings, in its effect, and its influence was probably quite similar to the directors' meetings because it was essentially the same people. Later on, that was reformed under the name of the Medical and Scientific Committee, which, at least in its title, had a fairly clear remit, that it was specifically to deal with, if you like, technical matters of medicine or research related, as opposed to financial and administrative matters.
So would it be right then to understand that across Scotland, common policies or practices might emerge through consensus, but directors were ultimately free to take their own course?
Yes, I think that certainly when I started was the way I saw it. I think possibly as time went on and there was perhaps more emphasis on external inspection and quality management and so on, the pressure to arrive at common decisions about practices and to some extent about policy was greater, and there probably were more decisions made that were the result of negotiation rather than consensus.
And then in terms of the National Medical Director, Dr. Cash, what essentially did you understand his role to be? And did he have any power to direct the directors of the regional services?
I don't think he had any power, and I'm not sure that his role was any more clearly defined in terms of lines of actual authority than my job as my regional director's job description left many things very vague. I think Professor Cash, Dr. and Professor Cash, was very aware of the limitations of his authority, and that he was a medic among medics, possibly primus inter pares, but not convincingly so. And for quite a long time, prior to the appointment of the first general manager, I do remember Professor Cash saying, this in various ways at various times, this organization needs a manager. I do not want to be a manager. I want to be a blood transfusion doctor and scientist. I think he felt that quite strongly.
And it was, as I understand it, 1990 when a general manager was appointed.
Mr. David McIntosh, I think it was 1990.
And you suggested in your statement, I don't think we need to go to it, but that prior to that, you yourself were essentially unclear as to whom or to what you were accountable. Well,
it certainly wasn't firmly recorded in terms of any documentation. I did my best to behave as though I was accountable to the National Medical Director because I felt that was a responsible way to behave. But I'm certainly prepared to disagree with him, but there were only, I think probably only one occasion when I, acted unilaterally on something important. And I think actually I can't remember if I consulted him, but I think I had his support, and that was when we launched the very first AIDS leaflet.
Turning then to the PFC, the Protein Fractionation Centre, to what extent did you have regular contact with the PFC, and what were the advantages or disadvantages of essentially being located geographically fairly close, I think?
Well, the director of the PFC was first of all Mr. John Watt, and then later Robert Perry, were members of the directors' meeting. They were considered, in equal status to the transfusion directors, and were active participants, not just in the meetings, but in the business of the BTS in general. I had certain quite specific contacts with fractionators, mainly in relation to intravenous immunoglobulin, which was a product that became very important. But with a couple of colleagues, I was very much involved in the sort of pushing for the development of that product. So I had a fair amount. That was sort of around the time that I was appointed, actually. It was part of the reason that I went to work in the BTS, because I thought this was going to be a big issue and I couldn't pursue the research I wanted to do anywhere else. But I don't think I had a lot of contact with the PFC personnel. But obviously we knew them well. We would chat to them about things, and we'd meet scientific meetings occasionally, and obviously at the formal meetings of the directors. I didn't spend a lot of time in the BFC.
Okay. The SHHD, Scottish Home and Health Department, you've told us in your witness statement that there were roughly annual meetings that would involve you, SHHD, and haemophilia directors. What was your understanding of the role of the Scottish Home and Health Department vis-à-vis the blood transfusion service, and in particular SEBTS?
Well, ultimately, they had the financial resources which were channeled through the Common Services Agency to the Transfusion Service. So, if the Home and Health Department disapproved of something or felt it was inappropriate at the time or it was too expensive, then basically it didn't happen. So they were the ultimate bosses, if you like. Generally, I think our relationship, we certainly, I had good relationships for quite a long time through one of the deputy CMOs, Dr. Bell, who was good at attending the directors' meetings. I used to meet him sometimes at various meetings in London. He was well informed and supportive and helpful. But I think the bottom line of the relationship was it was financial. And the other thing, which obviously cropped up on some occasions, was there was a strongish political influence, and that if we embarked on something or we were considering embarking on something which ministers didn't like for whatever reason, the SHHD officers would be the channel through which we learned about that. I must say that the bulk of the relationships in terms of contact with the department in Scotland were undertaken by John Cash. As the national director, he was the main, did most of the business with the department.
Did you, as far as you can recall, look to SHHD or to the Chief Medical Officer in Scotland or the Deputy Chief Medical Officers for advice or guidance? And if so, in respect of what kinds of matters? I
don't think so. I mean, I don't think that really there was anyone within the department there who had the expertise to give us guidance. I think it was more often the other way around.
In terms then of regional transfusion directors in England and Wales, did you have much by way of regular interactions, or was there any formal forum for interactions with your colleagues in England and Wales?
I don't recall that there was a regular formal forum. I interacted with some of the directors because of, we possibly were on the same working groups or something, or we shared a particular interest. Dr. Contreras, for example, and her team, Dr. Barbara and others, we had a lot of contact with them, mainly in relation to infection, but they were a forward-looking service and we borrowed ideas from each other quite a bit. We had some relationships with Dr. Harrison, who was then the director of the South London service, because we used to quite often send surplus red cells to them, because they had frequently had they're very, very difficult community and they were often short. And because we were driving to collect plasma, we often had surpluses of red cells. Dr. Wagstaff in Sheffield, I had quite a lot of dealings with, because he was very much a leader in terms of developing the sort of quality systems, I suppose one would say, and that was a national initiative which Dr. Cash and Dr. Wagstaff were both very prominent in.
And then, in terms of Northern Ireland, did you have any particular dealings with the regional transfusion service in Northern Ireland, other than through the regular attendance by the other Dr. McClelland at the SMBTS meetings?
Not really. I mean, much later on, I did a short spell on there, 2 or 3 years, on the advisory committee assembled by the Northern Ireland government for the North of Ireland service. But apart from that, no. I would meet Maurice McClelland at our meetings, and that was about it.
And then relationships with Hemophilia Centres and Hemophilia Centre directors. I'll ask you shortly about the arrangements for the supply of specific products. But more broadly, in terms, again, of information sharing, policy making, discussing policies and practices, were there regular meetings with Hemophilia Centre directors in Scotland?
There was, as you've, I think, already referred to, there was an annual meeting, which I can't honestly remember when it started, but it involved the transfusion directors, the haemophilia directors, or some of them, and there was always a representative of the Scottish Health Department there for quite a long time. It was a Dr. Aileen Keel, who was a deputy CMO and a haematologist as well. Those meetings were very much focused on, as you would expect, on coagulation products, very largely on factor VIII, because it was the big issue, and dealt with issues both of quantity of supply and increasingly with product quality.
We don't need to bring the document up on screen, but I'll read a reference into the transcript. PRSE 00000144 are the minutes of a meeting in January 1981 between SNBTS representatives and haemophilia directors, with attendance from the Scottish Home and Health Department, which says that the group hadn't met since 1977 but was now reconvening. Did it, as far as you can recall, thereafter meet fairly regularly?
I think it met annually. I think it may well have been chaired by the Department of Health, and they may even have convened the meetings. I think their interest was largely because of the financial implications of factor VIII supply, which were enormous. I can't tell you how long it went on for. Those meetings were probably still happening when I retired. Oh no, they wouldn't have done, because by the time I retired, plasma-derived factor VIII was no longer an issue. But probably until the ban on CJD ban on the use of British plasma or UK plasma for fractionation, I think those meetings probably did occur annually.
Now,
I've only seen minutes of a small number.
Now, in terms of haemophilia centres, specific haemophilia centres, your dealings were presumably predominantly with the Edinburgh Haemophilia Centre.
Excuse me, sorry for your sound is going. I'm having an internet unstable message. If you could possibly repeat that last question, because I missed bits of it.
I will. In terms of the specific haemophilia centres, is it right that your dealings were predominantly with the Edinburgh Haemophilia Centre?
I think they were almost exclusively with the Edinburgh Hemophilia Centre. I don't recall having dealings with the others, other than occasionally at more like scientific meetings.
And you had, I think, an office effectively adjacent to Dr. Ludlum, Professor Ludlum, in the old Royal Infirmary building?
Lost you again, I'm afraid. Got visual, but not sound.
Can you hear me now?
I've got you now.
Okay. well, we'll perhaps keep going, but if it keeps happening, we might have to take a break and see if we can.
We might have to see if we have to if we can fix up an audio link as well as the video link we've got.
If it's okay, I'll signal when if I lose your audio. Sorry to interrupt, but otherwise I'll miss it. Yeah.
Well, thank you very much.
So is it right that you had offices, I think, adjacent to or close to Dr. Ludlum, and so there was an opportunity for fairly frequent interaction in any event?
Yes, indeed.
Now, I want to turn next to issues about self-sufficiency and plasma supply. Sally, could we have on screen PRSE 0001556, please? This is another set of minutes of the meetings that we were talking about a few minutes ago, Dr. McClelland, SNBTS and Hemophilia directors, chaired by Dr. Bell from SHHD. This happens to be February 1984. If we could just go to page 3, please. The third paragraph says this: Dr. Bell emphasised that the aim of the SNBTS and of national policy was for Scotland to be self-sufficient, and although the department would not wish to intervene in what clinicians prescribed, it was not sensible to purchase imported material when suitable NHS product was available. From the point in time when you became director in 1979, Dr. McClelland, was it your understanding that the national objective was for self-sufficiency in Scotland?
Yes, that was, I think, widely shared. I think as far as the haemophilia directors went, they supported the concept, but their priority was and remained, I think, to obtain what they judged to be the best product for treating their patients, and that was not always the SNBTS product.
And what did you understand self-sufficiency to mean for Scotland?
Well, it's a very interesting question. I think somewhere in my statement I attempted some definitions of self-sufficiency from different viewpoints. I mean, simplistically, I understood it at that time as being the achieving a position where the Scottish Blood Transfusion Service, using only voluntary, non-remunerated donors, could produce the quantities of factor VIII concentrate, because that was the driving product at that time, that would meet clinical requirements. The joker in that pack, though, was the definition of clinical requirements, which escalated constantly, and have now reached a remarkably high level. So it was a great idea, but it didn't really acknowledge the steepness of the curve showing the increase in factor VIII utilization. And that was driven by the clinician's perception, which one must respect, of what patients required to keep them well.
Now, in terms of the targets for plasma supply, in broad terms, what targets did you have, and how and by whom were they set?
Well, this was one of the functions of the joint meetings, I think, between the haemophilia directors and the SNBTS. There was a sort of ongoing supply and demand process, which I think it was largely masterminded by Professor Cash, in which each year an estimate would be arrived at by the haemophilia directors, essentially, as to the number of international units of factor VIII that would be required for the following year or two. And that was converted by the SNBTS into kilograms of plasma, assuming a yield something in the region of 200 units of IU of factor VIII per kilogram. And that was shared out between the regional centres, the plasma target, I think largely on the basis of their population, but with the recognition of historical levels of production.
To what extent within SEBTS were you from the period from 1979 through to the mid-1980s, were you able to meet those targets that you were set?
My recollection is that we met them pretty regularly. I did manage to get hold of a spreadsheet eventually, which looks at the sort of performance against targets for the major components, and it would appear that as an organisation, we were pretty much hitting the targets nationally.
And do you have any recollection of the position in relation to the other regions of Scotland?
Well, I think they were certainly Inverness. I remember, which was a small region, it was probably constantly exceeded the target because they had, for the small population, a high level of collection, but they had an enormous wastage of red cells. Most of their collection was for plasma and resulted in quite horrifying destruction of donated red cells. The west of Scotland, I think, being the biggest centre and arguably one of the more difficult territories in terms of social and economic mix, deprivation, etc., did, I think, sometimes toil a bit. But broadly speaking, I think the centres delivered pretty well on the targets.
Did the need to meet those targets have any, as far as you can recall, impact upon the safety of blood and its components? Was there a trade-off between trying to provide sufficient and as against trying to keep the supply as safe as possible?
I really think there was not a trade-off there. I don't think, I'm not aware of ever feeling that the production target had didn't connect with what we were trying to do on a safety level. That was a separate issue.
Now we've had evidence in relation to England and Wales about the introduction of a formal Prorata system in the early 1980s. To what extent was there an equivalent system in Scotland?
I think it was. I think there was nominally a system, but I think it was probably knocked off course repeatedly by the demands for factor VIII, the fact that that the patients tended to be concentrated in the two large centres in Edinburgh and Glasgow to a very large extent, and they were always going to be the biggest users. So I think the critical question was pro rata in terms of what, and whether it was plasma production by each centre or population of each region. The driving factor actually was the number of severe haemophilia patients, the number with inhibitors, and to some extent the philosophy of the treating clinician in each city.
Can we have up on screen, please, Sully, PRSE 301736. So this is another of the annual meetings of SNBTS and haemophilia directors under the chairmanship of Dr. Bell. This is now 21st of January 1983. If we go to the second page, we can see, if we pick it up at paragraph 4, we can see the chair invited Dr. Cash to introduce a paper he'd prepared to facilitate discussion with regard to future SNBTS planning for the production of blood products. And there are references in other sets of minutes to similar papers being produced by Dr. Cash in different years. Trends in supply and demand for factor VIII concentrates. Figures quoted for the 5-year period 78 to 82 showed, 1, there'd been a sustained increase in the total amount of fresh plasma processed, although it was anticipated that increases would probably now level out unless there was significant further financial investment at the regional transfusion centres. 2, there'd been a decrease in the amount of cryoprecipitate issued from the RTCs, and 3, there'd been a substantial increase in issues of the PFC intermediate factor VIII concentrate. So would it be right to understand over that 5-year period from this an overall increase in terms of the processing of fresh plasma, regional transfusion centres producing less cryoprecipitate, the PFC providing more concentrate in broad terms?
That's correct.
And then if we go to the next page, there's a discussion at the top of the page about a target figure for the next 5 years, target figure having been agreed by the working group as a reasonable assessment of demand. I haven't taken you to the minutes of the working group. I don't think you were a member of the working group, Dr. McClelland, is that right?
I wasn't, no.
But its purpose in part was to look in more granular detail at trends and what might be required by way of plasma supply. Is that fair?
Yes, yeah.
And then we can see it says concern was again expressed about the amount of commercially produced factor VIII which was still being purchased. Members went on to discuss the regional breakdown of the usage of cryoprecipitate PFC concentrate and commercially produced factor VIII. It was noted that while purchases of commercial VIII had declined in Glasgow, purchases in Edinburgh had increased. Dr. Ludlum explained the reasons for the use of commercial material in Edinburgh were partly clinical and partly a policy of conserving a cushion of NHS factor VIII against an anticipated shortage when production at the PFC would be suspended to carry out alterations required by the Medicines Inspectorate. Just pausing there, what recollection do you have about this issue of increased usage of commercial factor VIII concentrates in Edinburgh?
Well, it was a constant. It never stopped, and it just slowly increased. The principal reason for it, I think, at this time was the concern, well, not concern, the opinion of the haemophilia director in Edinburgh that for some patients, some of the commercial products were actually superior to the PFC product. There may have been occasions when, at this time, when commercial products were being purchased because of shortages of the PFC product. But I think in 1983, the principal reason was a perception that they were of better quality, or the commercial product was, let me say, more suitable for certain patients.
And so, was it your impression or understanding, leaving aside any particular point in time at which there might be a shortage in a given month. But generally speaking, the use of commercial concentrates at the Edinburgh Hemophilia Centre was largely a matter of choice, was it, rather than because you couldn't supply enough plasma and the PFC couldn't produce enough concentrate?
I think it was mainly a matter of choice. The PFC certainly had difficulties in producing sufficient quantities of concentrate and producing a product that satisfied the requirements of the haemophilia directors, mainly in terms of its convenience of use, the time taken to dissolve the freeze-dried powder, which was quite an important issue for regular users. I don't believe that plasma supply actually ever limited, and other witnesses with more knowledge may refute this. I'm not convinced that plasma supply for the PFC actually was ever the limiting factor in the quantity of factor VIII produced, but I could well stand corrected on that.
And then the next paragraph records Mr. Watt talking about the effect of the refit at the PFC on supplies. And then the last sentence, if we go back on screen, PRSE, thank you, Sally. It's the third paragraph on the page. The last sentence of that paragraph, Dr. Cash emphasised that the Prorata system was not intended to be applied inflexibly, that products could be transferred between regions in the event of a local shortage. And then if we just go to the next paragraph, the chairman, so that's Dr. Bell of SHHD, stressed that the SNBTS had been set up to have the capability to cope with all Scottish requirements, other than those few therapeutic agents, the production of which might not be justified on a very small scale, and that in terms of national policy, the purchase of commercial products should be avoided so far as possible. Dr. Ludlum also expressed some misgiving that Edinburgh perhaps did not receive as much PFC factor VIII concentrate as it should pro rata. It was remitted to Dr. Cash, Dr. McClelland and Dr. Ludlum to resolve any problems which had arisen in relation to supplies to Edinburgh. Now there are various bits and pieces of correspondence in relation to that issue. I don't want to take time going through the detail of them, but do you recall anything now about any further discussions on the issue that was there being raised by Dr. Ludlum?
Oh yes, repeatedly. It was a constant theme, largely dealt with by my colleague Dr. Frank Bolton, who was a hematologist, which I'm not, and an experienced haemophilia doctor as well. So he was in a position to really talk professional matters with Christopher Ludlum about this. I think on this particular occasion, Dr. Ludlum was just perhaps being slightly opportunistic in making this point, because I don't think his centre was being shortchanged in any way. In fact, I think they probably had rather a large share of the available factor VIII from the PFC.
Now, just in terms of the actual mechanics, so we can take that document down, Sally. The actual mechanics for the supply of the commercial concentrates. Again, there are a range of documents. I don't think it's necessary to go to them in detail or one by one, but there are documents which, in the course of 1983, suggest that the commercial concentrates were obtained and held by the regional transfusion centre and then provided to the Hemophilia Centre, but that Dr. Ludlum perhaps was pushing for a system whereby the commercial concentrates were obtained directly by the Hemophilia Centre. Do you have any recollection of that issue?
Yes, I remember that quite clearly. I sort of inherited this issue. There was a very small, when I took over, there was a very small purchase of one or two commercial products, which actually stopped. But when the Dr. Ludlum took over the took over the haemophilia care in Edinburgh, he revolutionised the way, the approach to treatments to a much more intensive type of treatment with rather different objectives to his predecessor. I've forgotten the specific question. Forgive me.
It was about the mechanics of supply.
Yes. Well, Dr. Cash, and I think encouraged by the department, the Scottish Home and Health Department, was very keen that the transfusion service should, as it were, be the agent retailer for commercial factor VIII products to the consultants. Dr. Ludlum was never happy with this arrangement, and I can't remember the precise details of when or how it happened, but the BTS relinquished any claim to be the, if you like, the pharmacy for commercial blood products, and that function was transferred to the hospital pharmacy, which was the conventional arrangement in all other hospitals, I think. But Dr. Ludlum was very insistent on that, and I have to say it was logical, and it removed from my responsibility something that was becoming an extremely difficult problem, because one was under pressure from the Department of Health to curtail expenditure on commercial factor VIII products, which was rising rapidly, and it was simply not in my authority to do that.
During that period of time before it changed, as you've described, when commercial concentrates were obtained and held by the Regional Transfusion Centre, who made the choice of which commercial concentrates to buy, whether it was Armour's product or the Immuno product? Was that something upon which your centre had a say, or did you simply acquire whatever it was that Dr. Ludlum asked for?
I certainly never had a say in that. When Dr. Bolton came, I don't think he did either, although he was competent to do so. I think we ordered at the request of Dr. Ludlum.
Now, the document we were looking at a few moments ago was looking at the question of use of NHS concentrates versus use of commercial concentrates. There was another issue which arose in relation to concentrate usage, which I wanted to just ask you about briefly. PRSE 000363. This is a letter you wrote, I think shortly after the meeting we were looking at, minutes of which we were looking at a few moments ago. 2nd of February 83, you to Dr. Cash. It says, following the joint meeting of Haemophilia and Transfusion Directors, I've been thinking about the request made by the Chairman that you and I with Chris Ludlum should review Edinburgh Factor VIII use. On reflection, I'm not sure this meeting can help much, since I'm satisfied that Frank Bolton has worked hard and consistently to negotiate a reasonable approach to Factor VIII provision with Chris. And then it refers to some correspondence, presumably between Dr. Bolton and Dr. Ludlum. And then the last paragraph you say, my conclusion is that while I'm more than happy to meet with you and Chris and Frank to attempt to resolve the problems, this really isn't the whole answer to the difficulties. I would suggest that there's a need for a peer review by the haemophilia directors, producing some clear guidance as to a reasonable level of consumption for the South East haemophiliac population. Now, looking at that last paragraph, is it right to understand that you weren't simply concerned here with the question of why is the Edinburgh Centre using commercial concentrates when there's NHS concentrates available? You were concerned with the question of how much concentrates, be it NHS or commercial, were being used at the Edinburgh Centre. Is that right?
That's correct.
And then if we go to your...
I could just say, I was sorry to interrupt. I was concerned because I didn't know. I really did not have the the knowledge or to make a judgment on this. And I felt that the only people who could do that would be the people who were responsible for treating the patients. And that was the suggestion that I made.
And then if we could go to your witness statement, WITN 6666001, page 35. Paragraph 103, if I can just pick it up in the 5th line, you say frequent exhortations to clinicians to moderate the use of PFC factor 8 were not noticeably effective. And then you go on to suggest that reflects the fact that haemophilia clinicians had a duty of care to provide best treatment for their patient. Was this, as far as you can recall, a problem limited in terms of Scotland to the southeast region, or was this, as far as you can recall, a broader problem across Scotland?
It was certainly a problem in the west of Scotland, which had obviously most of the haemophilia patients. I really don't know about the other regions.
And do you have, beyond what you set out in the remainder of this paragraph, do you have any sense of why it was that exhortations to clinicians to moderate the use of the factor concentrate did not have any discernible effect?
Yeah, absolutely. I mean, if I'd been a haemophilia patient and my consultant was offering the prospect of, or my child, prospect of actually being able to go to school without constant interruptions and to be able to be treated at home rather than having to come into hospital and waste days hanging around, I would have been pushing very hard for more factor 8 because that was the key to normalizing the life for a lot of these patients. This was inevitable.
Factor 8 concentrates obviously brought with them a known risk of transmission of hepatitis, if we simply take the position as at 1983, and unfolding at that point in time risk of transmission of AIDS, which I'll explore with you in more detail after lunch. To what extent did the exhortations to clinicians include a reminder or reinforcement of the fact that the greater use of concentrate, potentially the greater exposure to viral transmission?
Well, that was something that was very much in the front of our minds, and I cannot honestly remember the words that were exchanged during these many discussions involving both myself and Frank Bolton, but the haemophilia clinicians were very capable people who read the literature just the same as we did. So they certainly knew about these risks, and we certainly pointed them out as a concern, and our hope and expectation that products made from indigenous donors' plasma would carry less risk of importing new infections. And that had been part of my own learning, minimal learning about haemophilia ever since I was a houseman, with one of my consultants being the previous haemophilia director, who was very strong on this point.
And we can take that down. Thank you. Without going to the text of your evidence to the Penrose inquiry, I think it's right that your evidence, I can't recall now whether it was written or oral or both, you recalled that Dr. Davis, I think it was a proponent.
Dr. Howard Davis.
Yes, was a proponent of cryoprecipitate because of he regarded it as a safer product in terms of risk of transmission of hepatitis.
Absolutely, and that stuck with me because I had great respect for him as a very careful and thoughtful clinician. I mean, there was a value judgment there in that he obviously felt that the risk of using a concentrate, particularly one that was important, just on basic epidemiological principles, that the risk was bound to be greater than something that came from home, from local donors. And he obviously placed more value on that than he did on the possibility of improving the clinical condition, improving life for the patients. Now, I never had that discussion with him. I was a bit young and innocent, but he must have made that judgment, and it's a very tough judgment to make.
Now, just want to ask you next a little about plasmapheresis at the centre. We saw that reference in the inspection report to there being, as at 1982, I think 3 beds for manual. Sorry, have you lost us again?
Yeah, just if you could just repeat that last question.
Yes. So I'm asking you next about plasmapheresis.
Yeah.
The inspection report recorded that, as at the date of the inspection, there were, I think, 3 beds for manual plasmapheresis. What use was there of plasmapheresis as the years went on in the 1980s at the centre?
Well, if I can just first quickly deal with the inspector's comment, we had a very small plasmapheresis room, and it was purely for the collection of plasma from donors who had high levels of antibody, either to tetanus toxin or to the rhesus antigen. And these were made for making specific immunoglobulin products for anti-tetanus or for the anti-D immunoglobulin used to prevent hemolytic disease of the newborn. We did not, at that era, do plasmapheresis for fresh frozen plasma. And I was surprised at the medicines inspector's comment that up to 7 or 8 beds would be okay, because as I explain in my statement, manual plasmapheresis is potentially quite a hazardous procedure, because to take a pint of blood, you have to disconnect it from the patient, put it in a centrifuge it, separate the plasma, and take it back to the patient, reconnect it, and re-infuse the red cells. Now, if somebody is a bit careless or loses concentration or their bleep goes or something, it is not impossible for the bag of red cells to be reconnected to another donor, which can have a variety of very serious consequences, including a major ABO incompatibility or the transmission of infection or something. So we would never have considered, I would never have considered expanding manual plasmapheresis. When Dr. Gillen joined us, and I think it was probably about then, we first had access to a generation of plasmapheresis machines made by a firm called Hemonetics, which were designed to be much easier to use and much more convenient for both the operator and the donor. And we did institute a small, modest-sized plasmapheresis program for FFP. And I think Dr. Gillen gave evidence about this last week. It was really mainly his baby as donor consultant. I have unfortunately not yet been able to get data that I totally trust about the quantities of plasma collected in the southeast by plasmapheresis, but it was never very large.
You said
we elected not to expand that programme.
You said in your statement, I don't think we need to put it on screen, but the reference is paragraph 86, that given the necessary funding for the machines, accommodation, staff and disposable plasma collection could have been expanded to substantially increase production of FFP. So the potential was there if you'd chosen to go down that route and if funding had been available to have a more extensive machine plasmapheresis programme.
Absolutely, and I think on 2 occasions, produced a sort of, if you like, a business plan for doing precisely that, and using a slightly different model, which is used in many other countries, of actually going to a local community, and I'd selected 1 or 2 where there were always massive queues outside the blood donor sessions, but actually setting up a little local shop front staffed by a small number of people with, operating these machines, which would have been extremely economical and could have, 2 or 3 centres like that would not have been hugely expensive to establish or to operate, and could have produced a great deal of plasma. So it was entirely possible, but there was never any enthusiasm at either the SNBTS top level or the Sovereign Health Department to pursue it. So having had 2 goes, I gave up on that. Do something else.
Now, I just want to ask you then about a sentence in your statement. So I will put this up on screen. WITN 6666001, and it's page 35, please, Sally. We've looked at this paragraph 103 before. I just want to ask you about the last sentence. You say this: I must add that my personal opinion was then and remains that there would have been both practical and ethical problems in obtaining the increasing quantities of plasma required from volunteer non-remunerated donors, whether by whole blood collection or by plasmapheresis. And Dr. McClelland, I've been asked by a number of representatives of core participants to ask you to clarify what you mean there by practical and ethical problems.
Yeah, well, the practical problems would have been very substantial, because one would have, to meet the sort of levels of factor VIII requirement that we're seeing more recently, and I have some numbers for that if you're interested, we would have needed a lot of plasma centres. The quantities of plasma that would be required to meet anything approaching the current consumption of factor VIII are absolutely enormous. There is a finite, on the donor issue, there is a finite pool of people who are can be recruited to donate on the grounds of both their willingness, their proximity to a donor centre, their health, their weight, their age, and so on. For example, a very high proportion of women of childbearing age cannot be accepted as blood donors because their hemoglobin level is naturally below the point at which it's safe or acceptable to bleed them. So there's a finite number of donors, and I believe that there is a finite number of times that you can reasonably expect a volunteer, non-remunerated donor to turn up and give plasma. The limit set by the European authorities, if I remember rightly, is 15 litres per year, which is already quite a hefty chunk of one's protein content. The commercial companies certainly, again, I'm recollecting, and I may not be exactly correct, but I think if one looks at the quantities of plasma collected from commercial donors, they're in the region of 50 litres, 50 litres per year. And I have very serious reservations about the ethical basis for subjecting people in one part of the community to expecting them to make that sort of level of loss of their own body tissues. I would personally, and this is a personal view, as I've said, have very deep reservations about embarking on a program that depended on asking people, expecting people to make that level of commitment, and to have, apart from anything else, to have 2 large venipunctures every week and give up a minimum of an hour of their time just for the procedure. This is why the American plasma companies have depended so heavily on paid donors who are mostly from very low income groups. I showed the Penrose inquiry a little handwritten poster which I photographed on the window of a plasma centre in the United States. You've probably seen it.
Yes.
You know, $10 a shot reduced to 8 or something like that. And the centre nurse manager told me, oh, well, it's a Thursday, there's nobody here because it's dole check day. And, you know, that's what it's about. That's why I had intended to delete that sentence, because I thought it, you know, might be unduly controversial, but it's found its way into the version that you've got.
Is it right then, very broadly, to understand your evidence in this way? As far as SE-BTS is concerned, you were, as far as you can recall, generally able to meet your targets.
Yes.
With additional funding and resources, you could have, not just through machine plasmapheresis, but more generally, you could have increased the amount that you were collecting and processing. But for the reasons you've just given, there would come, that's not something that could be done infinitely. There would come a point in time at which you could no longer get, for the reasons you've explained, in your view, enough by way of voluntary donation. It's a somewhat crude summary, but is that inaccurate?
No, that's fine. That's basically what I'm saying.
I think there's just a bit more to it than that. It's also your view that it would be wrong to try to persuade people to do more than you feel it would be really healthy or satisfactory for them to be asked to do. That's as I've understood what you've been saying.
That is absolutely correct. That is absolutely correct, sir. I actually do feel it would be quite wrong to ask an individual to subject themselves to 2 invasive procedures a week, effectively, forever, and to the withdrawal of very large quantities of protein from their body composition, with, you know, a small but finite instance of adverse reactions associated with any of these extracorporeal procedures. It's a very big ask. And I think it's, I personally, and it's a very personal view, I feel that constitutes an unreasonable request to an individual. But that's my, and I'm sure it's contentious.
The request or the invitation, whichever way you put it, to someone to give plasma need not necessarily have been as much as the Americans, 52 times a year or twice a week. It could have been much less if it was the European model. But did you have objections to that on the same basis or not?
No. I think hope I made it clear that I was actually quite enthusiastic about establishing some small, focused, dedicated plasmapheresis centres to serve the needs of communities where I knew there were large numbers of donors who often actually couldn't get the opportunity to donate. And I would have been perfectly happy to look very carefully at the European criteria for the maximum, which I think is 15 litres a year. I've never given that serious consideration. Personally, I would have started off at a lower level for each donor, but we could have collected a lot of plasma that way from willing donors without subjecting them to anything that I personally felt was unreasonable, and I think fairly modest cost.
So your view then is very much linked to the scale of what was proposed so far as the individual donor is concerned.
Yes.
Thank you.
Dr. Angela, if I can just add, Dr. Angela Robinson published a paper on a pilot scheme for plasmapheresis prior to in the build-up of plasma for the blood products laboratory, and gives some very useful sort of figures about the sort of quantities that can be produced from a 6-bed plasma dedicated unit, and she's put some costs in there. And that is the sort of model that I would have been quite happy to institute. I've sent the reference, I think, to the inquiry some time ago.
And by quite happy, you mean you would have liked to?
I was keen to do it.
Yeah.
So I completed that particular topic, and so probably a convenient point to take our lunch, given the time.
Yes, it is. 2 o'clock.
Thank you, sir.
2 o'clock. I hope that gives you long enough for lunch.
Sorry, Dr.
Could I just say, we still have some sound problems.
I hope we will be able to attempt to resolve the sound problems so far as we can over the break. There's a technician, I think, there with you. So
Yes.
I hope that they will be active, but I hope that we'll be able to start again at 2 o'clock. And I hope that gives you enough time for some refreshment and a break. And we'll start again then and hope that we have a seamless operation of the IT this afternoon.
Thank you, sir.
Thank you.